Good afternoon, everyone. I'll be sharing our experience on autologous fat grafting. So, autologous fat graft was introduced by Newber. He used an open technique for fat transferring. Now, with the advancement in the technology, it has found wide application in aesthetic surgery, like facial recontouring, scar management, etc. So, ours is the first study from India to report its use in sockets. This is a retrospective interventional study which was done between January 2019 and March 21. So we have used autologous fat graft in various types of patient, and these are the parameters we assessed for each patient respectively. Coming to the surgical technique, all the cases were done under general anesthesia. Uh, the donor site we selected to be the lower abdomen. The A small stab incision was made, and the tumescent solution, which is composed of 100 ml of normal saline, 30 ml of 2% lignocaine, and 1 ml of adrenaline, was introduced in a fanning method. After 5 to 10 minutes, a 3 millimeter Coleman cannula fitted with a 10 ml syringe and luer lock was introduced, and fat was harvested using a negative pressure technique. So then it was left alone to settle down using the gravitational force. After it has settled down, the serum was separated from the fat, and the remaining fat was transferred in a 3 ml of syringe, and then using a 20 gauge cannula it was injected in the recipient site. So the remaining fat it was stored at minus 20 degree for 4 weeks, and after 4 weeks if any patient required repeat injection it was given. We have followed up the patient at the first week, fourth week, and 6 months. So we have included 17 patients. The mean age was 30 years, and we found that orbital volume augmentation was the most common indication for AFG. In our cohort, the trauma was the most common etiological agent, and in the orbital cases of volume augmentation, the anophthalmic socket was the major number of cases, followed by residual enophthalmos after orbital fracture correction. We have used approximately around 5 ml of fats for these cases, especially the socket and the residual enophthalmos. And we noted that further augmentation was required for 3 patients, two with the residual enophthalmos and one with superior sulcus deformity. We have followed up the patient for a mean of 6 months, and resorption of this autologous fat graft was noted in 3 patients. Now, out of these 3 patients, one required repeat AFG harvestation. One patient had already contracted socket and had already undergone multiple procedure, so we repeated a dummies fat graft for that patient. And the temporal hollowness patient was a RB patient post radiotherapy, so we assumed that could be the cause of this atrophy. Now, this is one young lady who had undergone fracture repair elsewhere and presented to us with superior sulcus deformity. And this is the outcome at the final checkup after autologous fat graft injection. Similarly, this is a middle-aged man who had undergone trauma and he developed a tear trough deformity. And this is the outcome after autologous fat graft injection. Now, this is the outcome we achieved in our socket cases. Now, this Sydney Coleman, he introduced the latest technique of autologous fat graft transfer, and the usual donor site is abdomen. So it has been noted that harvestation with 3 millimeter of Coleman cannula give optimum results. However, smaller cannula is used for better results. And we noted that structural integrity is better with the sedimentation method. Slow injection assures better fat imbibition, and with volume augmentation in sockets, we can avoid surgical intervention like DFG. So, optimum outcome is achieved. Fat cells also possesses mesenchymal stem cells, which gives a better skin remodeling also in this patient. However, much said, AFG survival is unpredictable. So, blindness is the most severe complication that can occur. It occurs due to intraarterial injection of autologous fat. These are the limitations of our study. We could have taken a control arm with centrifugation, but we couldn't achieve that. So, to conclude, it is a minimally invasive technique, and it can be used in the correction of residual enophthalmos. It gives optimum outcome. Cryopreserved fat, although it has been noted that there is depletion of stem cells in them, but we have found optimum results. However, further studies are recommended to see the fat survival and all. Thank you. These are